All right. Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller. And today we have Dr. Sarah Nasir joining us all the way from California. And it's very early in the morning for her. But Dr. Nasir, welcome to the podcast. And why don't you tell us a little bit about who you are and what you do?
Dr. Reller for inviting me, and hello, Tampa Bay. Nice to be connecting with you guys today. I'm Dr. Sarah Nasir. I am an osteopathic family medicine and addiction medicine physician. I'm currently working as a full-time addiction medicine specialist, also an entrepreneur and founder of Transcendant You, which is my coaching service to help people overcome their limits to go into a fulfilling and thrilling life.
I'm very excited to have you today because we have not had anyone with the specialty of addiction medicine, and I know it is a little bit unique in your path toward it. So, can you tell us how you kind of got into that in the first place?
Yeah, sure. It's been a wonderful journey. I was exposed to the impact of opioid epidemic, the methamphetamine use when I was in medical school, but I didn't realize what a huge epidemic I was in front of. And then as my medical journey continued in residency, when I was finishing up in upper state New York, that's the time we started to hear more and more about the opioid overdoses and the epidemics rising. And apparently, we were sitting in the opioid belt going from Mexico to Canada. So there was this route that was going through our city. And at that time, the prescription opioid dependence turning into abuse was huge because there wasn't as much regulation with the opioid prescription. And there was that desire to make pain one of the vitals that you want to treat in patients. So whoever came with pain was also getting easier access to a large quantity of opioids. And so there was that iatrogenic or medicine or medical care induced opioid dependence at that time. So when I was in residency, there was this like huge pendulum, like, it goes to the extreme and it's ready to swing back the other way. So I was at that like crucial crux of the time when there was all this crackdown of opioid prescriptions and further restrictions. Then the patients, with all of a sudden, they didn't have any prescriptions to control their withdrawal symptoms after their body became dependent on it. And then the turn went towards heroin. And as I continued to, in after residency as an attending, got my data waiver to prescribe buprenorphine, what I started to see after was that fentanyl was becoming huge. And fentanyl is for the drug dealers and the creators, it's more cheap to make and they make more money out of it. So it is a very lucrative solution or way of making money for the cartels and the sellers. And so that is now what's, I heard one of the DEA presentations, they were showing that about 7 out of 10 fentanyl pills had deadly dose in it. So it's not that 7 out of 10 pills had fentanyl in it. It's that 7 out of 10 pills had a deadly amount of fentanyl in it that can easily cause overdose. So there is a lot of, what do you call it, scary things happening in my patient's urine. They come and we do the urine test as part of the admission process at the methadone clinic I work at. And we see like weird combinations. The patients think they're doing heroin or just oxycodone pills or something, more benign. And then urine is showing like fentanyl, methamphetamine, ecstasy, and they're like, where's ecstasy coming from? I don't even do ecstasy. And so just raising that awareness. And now 48 out of the 50 states have xylazine in the combination, which is like an alpha 2 blocker. Its street name is Trank. This is medicine alpha 2 agonist for the medical people, which is used to tranquilize horses. And it is being mixed in the fentanyl, and people are overdosing on it easier. And the Narcan that we use as an antidote to opioid overdose, that doesn't reverse the effect of the xylazine. What ends up happening is you're seeing more overdose because of it. Apparently is increasing the potential or the power of the fentanyl to get people to relax, because people normally do fentanyl or opioid type drugs for recreational purposes to feel relaxed and calm down. And so this tranquilizer, if it's tranquilizing a horse, is going to tranquilize a human for sure. And the other very interesting picture that comes with xylazine is it can actually cause local necrosis. So if you're injecting it, you might find patients who are seeing necrosis, which means rotting of the flesh on the skin. So it's some scary things out there, but it's very fascinating. I'm loving the work that I do because to me, it shows what is it like? I feel like it's very impactful work. I feel that when I'm able to take care of a patient and guide them through the process of going from somebody whose life is controlled by this recreation turned into a chronic disease into a person who's back in charge of their lives. They have their bodies back, it's stabilized, so they can focus their mind and their spirit in creating a supportive environment for recovery and sobriety. It is a wonderful feeling because you see that they start to become contributing members of society. They start to be more present as a family member. So you heal families, you heal communities. To me, it's an act of service very close to my heart because in medicine we all come into it because we want to make the world a better place, and I feel that this has allowed me to create a significant impact in a population that often has a lot of stigma and restrictions as well as self guilt and humiliation in this field. So that often makes them feel like I'm not worth it. So, what's the point? And there's a lot of traumatic events in life or adverse, childhood adverse events or even maybe adult adverse events that push them into this in the first place, oftentimes. And being able to help them connect with their human self, that, it's their health, their purpose, their existence is so much more than just being defined by this disease. That is gratifying to me. That is how I practice medicine, by helping, I'm going to use the word patient here, by helping my patients realize the power that they have inside of themselves and, designing their lives to be what they want it to be so they enjoy it to the best of its greatness. That really gives me a lot of joy.
You said so much there. It was amazing. I want to ask you more about one, you said you trained, I think, in New York. I wanted to know more about this. You called it what, opioid belt? So
Yeah.
where I didn't know that term. So what is that? You said it's down from Mexico up through Canada, but where did you do your training so our listeners know kind of what you were exposed to then?
I did my training in Elmira, New York. So it's, after that is Rochester. It's close to the Niagara Falls, like 2 hours southeast of it. So Canada's not too far away. It's like 4 to 5 hours of drive and you're across the border. And so it did that East Coast route. I think there's a few other routes throughout the country, but that was the convenient way apparently at that time to get the drugs up to Canada.
Okay, so I trained in Baltimore and we definitely had an opioid epidemic there as well. And there are definitely, methadone clinics that we worked in residency. And some of the people who still that were in family medicine with me that stayed on, I know they had done some fellowships in addiction medicine as well. So, but I feel like kind of naive from everything that you've just said. Basically, I don't know why patients or people or the population use certain drugs. And you said they use fentanyl for that tranquilizer type feeling, right?
Yeah, for calming effect. Yeah, but the drug trank is now being mixed by the drug makers to get people more hooked and also reduce their production cost. And it's like the bag of chips, right? We've been paying more and more for the bag of chips, but you have less and less chips and more air, and it costs more and more. So they're definitely keeping up with inflation there.
And more impurities, like you're saying, like they're just throwing all these different other drugs in there, which is causing like overdose problems, correct?
It definitely leads to that because they're trying to make it more addictive. They're trying to make it more attractive, harder to get off of, because that is how I tell my patients that that is what they care about, is how much you can pay out of your wallet versus when you come to the medical care. Many people have a lot of negative feelings towards the healthcare system and sometimes the medical management system. But at the end of the day, we are not going to turn somebody away. Our first and foremost commitment is to saving lives. First is do no harm, then save lives. So that's a big difference. I like to joke with my patients between your drug dealer and your doctor.
Yeah, you're definitely saving lives in what you're doing, no question about it. I think that I also wanted you to explain a little bit. You mentioned when pain became another vital sign. What did you mean by that? Like you were saying something about how it became obvious or something?
No, that's a great question. So, in the evolutionary process of this issue, so at the beginning, we had, like, just before this crackdown happened, the pendulum had gone to another extreme. So hospitals, healthcare systems, they were trying to push for patient satisfaction by making pain as one of the important markers of patient satisfaction. And also in regards to, you check for pulse, you check for oxygen saturation, temperature, blood pressure. These are the things that we normally, when we're taking care of patients in the hospital, those are some of the things that we need to keep a good eye on. And what was happening in the beginning, when pharmaceutical companies of medicines like Percocet, Oxycodone, Norco, they were really trying to promote doctors to encourage them to prescribe this pain medicine, because when patients are coming in pain and you can take care of their pain, patients are happy. And so they'll leave a better review and they'll continue to come back. That customer service, that felt like it was part of the overall well-being. And so there was that huge pharmaceutical involvement that impacted in the propagation of this. And at that time, I'm not sure if it's because the data wasn't as available, or I don't know if there was any fudging. I have to look into that a little bit more. But that allowed a lot of patients to become dependent on opioid against their will. Even though they were not straight drug users, they could be patients with fibromyalgia, chronic back pain. The opioids were being prescribed very freely for that. And slowly the patients became dependent. And what that means is that your body changes to protect you, not just biologically but chemically as well. When you are seeing this exogenous or foreign chemical in your body to such a high degree, your body doesn't like it. So it starts to reshape itself by making less of naturally occurring hormones like endorphins, which are the feel-good hormones that gets released when you do things like exercise. It's part of that natural reward pathway in our brain. So your body starts making less of it because it doesn't want you to constantly be high and out of its body, like not be present within yourself. It starts to pull out the opioid receptors from the brain where the endorphins would normally attach to the opioid receptors. And on the other end, one of the hormones that would get released is dopamine, which is your reward hormone, one of the reward hormones. And so your body wants to make less of it, because when one of the things that opioids do is it takes away your desire to breathe. That's one of the things that kills people when they overdose, is that they stop breathing. And that asphyxiation, that lack of oxygen, is what leads to an eventual death in the patients. And so your body doesn't want you to die, right? So it starts to adapt to this and it starts to change itself. When you don't have this constant amount of this opioid coming in from outside that your body is used to, then I like to use the example, if you're on the ground here, if your body feels here, metaphorically, as you continue to use drugs, your body might be down here. And so without that added step to bring you back to level, if your body's down here, this is not where it thrives. This is not a functional place to be. And then you start to get all these withdrawal symptoms like body pain, runny nose, diarrhea, nausea, vomiting, difficulty sleeping, feeling anxious, because your body feels like it's dying, right? It's falling down the hole. And that noxious state of existence pushes people to go and want to use, even though you have never picked up a drug before to get that for recreational purpose, to get high. Just that constant exposure to this unnatural chemical in your body changes your body. So when we are doing medication assisted treatment for opioid use disorder, we are giving medicines like methadone, which is an opioid itself. We are using medicines like Suboxone is a brand name, generic name is buprenorphine, same medicine, which is a partial agonist, which means if there's opioids in the system, it's going to punch it out and give you withdrawal. And if there is no opioids in the system, then it's going to actually attach to the receptors and stabilize you. So these are other ways of doing it. There were some other medicines like naltrexone, which is good for alcohol use disorder too. So if you have a patient with opioid use disorder and alcohol use disorder, naltrexone or Vivitrol is another name, that's a brand name, that can help with that. But my favorite is the buprenorphine because it has a much better safety profile. And oftentimes they put the Narcan medicine in it. So that's the Suboxone. And that reduces your risk of overdose as well. It's tamper proof, so you can't just turn it into something you can inject. If you try to snort it, it doesn't have the same effect. So I like that medicine a lot better. It requires less oversight. But the other ones, methadone clinics, so far the rules have been that you have to go to a methadone clinic to get the medicine. But the rules are at this time changing, where they are looking at addiction medicine specialists can prescribe it and patients can pick it up from the pharmacy, which would bring a lot of flexibility into people's lives. But for now, it brings accountability to the patient. So sometimes when you are caught up in this world, you lose sight of and touch with, things of rituals of daily living that just pushes you further and further away from a life of sobriety. So the methadone clinics were supporting that. The other important part of addiction treatment is getting counseling and behavioral therapy to help you with the mindset, because the medicines are just stabilizing the body, but the driver of the body also needs that support to learn skills, surround themselves with supportive environments, such as the people around them. If they need to heal with their family, that's an important thing. Not hanging out with people who are their dealers, and maybe finding people who have moved on to the next stage of the recovery and are thriving, getting a job, getting your finances in order, having a place to live. Homelessness is so huge in this population, and it doesn't help when they're using to climb out of that stage of life neither. So many aspects of life gets interrupted because of this disease. So once again, going back to the joy I get out of doing this is being able to help somebody reclaim their lives, their place in life, and seeing them go from somebody who has lost weight because all they care about is just stabilizing their body and feeling good temporarily, to somebody who has reached that level of life where they are in control of their happiness, where their body is keeping up with it. They look healthier. They have better relationship with their families. They are holding a job. It's so beautiful to see.
Once again, you said so much good stuff. It's really interesting how that pain as an extra vital sign has kind of caused a little bit this problem. And it's very sad at the same time. They were only trying to help people, and the patients end up getting addicted to the medicine. And then I thought it was interesting. I mean, you did a really good explanation. You were basically describing what addiction is and then the withdrawal symptoms. So I think we see parallels in that in other addictions that we deal with as well. Like you mentioned, alcohol and smoking, and sometimes it's debatable, but like food addiction as well. So I see that. And we even use the similar medications like naltrexone for all of those things too. And I think it's interesting the way that you're treating the, you're a leader of a methadone clinic, right? Or the director. Yeah. But you prefer the Suboxone so that it's just a better like profile without that having that risk of, you know.
I Suboxone when I was doing primary care and an outpatient medicine. So that's what I started with. That's what I was prescribing. Definitely, I appreciate the freedom that it gave my patients. With methadone clinic, this is all I'm seeing because, regulation wise, we're allowed to do either methadone or buprenorphine. So we do buprenorphine as well. But most of the patients that come, they benefit more from the routine and the structure that a methadone clinic is bringing into their lives, or they didn't tolerate the buprenorphine. So they get this treatment very closely monitored because it is a pure opioid. So we do have to be careful with it.
I mean, they have to go to the methadone clinic every single day, correct?
Yes, there are milestones. If they're able to hit those, then they earn some take homes, and the maximum amount of take homes is a month, almost 4 weeks long. So that needs to be earned. And in the process, that means they're also gaining some life skills that are established and amplified in the process. So that is the benefit for those patients who need that structure.
So how do you use all of your expertise in these, I guess, on all the different measures of that you've helping patients, like with the methadone and the other clinics that you do? How do you do that with your other practice, that Transcendent You? Tell us a little bit about that.
So in Transcendent You, with the recovery coaching part, which that's one of the areas that Transcendent You focuses on, this is, helping the patient. So my coaching is based on individual purpose by helping them connect and identify their purpose, which brings them fulfillment. And we use meditation. So this is not a prescription medicine based. This is that extra support of using neurolinguistic programming, using connection deep within, as well as identifying what's important to them, helping them overcome the mindsets that hold them back, education based empowerment. And because a few of the things that promote addiction in the first place, as we discussed, is some of the adverse events they might have encountered in the past. And instead of dealing with it in a way that is productive and actually resolves the problem, oftentimes people turn to temporary reliefs to run away because it's so much for them to bear. So that trauma centered approach of helping them heal, that is taking care of the root cause of the problem. And then once that happens, there's that release, and then release of all that pressure that they've been driving with. And so once they are able to let go of that, the weight that weighs them down, it's easier to then see that you don't need these chemicals to achieve that happiness that you were trying to get. And with one of my patients recently, I was saying that, these chemicals, they give you like very fast highs and then they come crashing down. So that's temporary. Your body's not ready physically, chemically to be able to withstand that. Versus if you train your body to continue to achieve that higher state through hard work, through finding things that give you joy naturally, and you continue to push yourself through transformation into that state of higher state of existence, you are living in that high, and your body is equipped to tolerate that and sustain it. So you build your stamina, you build your endurance into being a more powerful aspect and version of you. So you don't then need those spikes that comes with a crash. So helping the clients help understand them, what that higher state looks like, and then equipping them with that mindset, helping them become their own best friend and their own advocates first and foremost, so they can achieve that state. So that's what the coaching does. And that's something I can do across the state. With the prescriptions, I'm only in California.
Yeah, absolutely. So how does that differ, I guess, from the CBT? Do you find it, or is it similar?
I think there definitely is a lot of similar aspects of it, but with the coaching, what I've found is that CBT doesn't look into things like NLP or hypnotherapy. Those are some of the other tools that are, I'm calling it tools of the personal development science. I think that really makes it a little different. And then The other thing I've found is that CBT tends to be more from a power position to a recipient position, versus with coaching, the one who's leading the conversation is the person. So there's that accountability. The person wants to be there, and the coach's job is to help them achieve their goals. Versus CBT, the medication treatment, these are more prescriptions. So, I mean, definitely now we practice patient-centered medicine. So we try to involve the patient, where in the past it was like the doctor was like the father figure, whatever they said is where we go. So over the past century almost, we have moved towards that. But still, it's like a doctor saying, don't do this, you know. So I find that oftentimes, even as a patient, sometimes myself, it's more like receiving knowledge and guidance from somebody who knows more, versus when I have a coach guiding me, it's more like they are helping me train myself to achieve my goals. So I'm more present. I'm the one in charge of saying that where I want to go. But when I come across that block, that mental block, the coach comes and helps push through that block. It helps you set those accountabilities, take something, a big goal that seems so daunting by myself, and then being able to sit down and make it less daunting by coming up with doable steps together, and doable meaning doable for the person who's getting the coaching. So it's customized life guidance in that way, using your own skills and using some other skills to tap into it. Versus cognitive behavioral therapy, it's great. Insurance covers it as well. So that's the benefit of it. It helps, but I've found that not everybody's fully present all the time, maybe just because they're not at that stage of life as well. So I hope that answers that question.
No, definitely. I mean, it does seem like coaching would be very, very beneficial and maybe even more so than the CBT. And I think everybody should be looking into that. And we have some listeners who are actually healthcare professionals who may not specialize in addiction medicine. What do you recommend that they encounter patients struggling with addiction within their practice? What do you recommend?
Definitely recognize first and foremost that they're human. They have a story. One of the hardest things to do, and I did it myself, is to recognize your own prejudice. I didn't mention in my journey when we were talking about it initially, is when I first was exposed to it in medical school, it was in a, OB, the birth area after newborn station. I saw a newborn going through what's now known as neonatal abstinence syndrome, where the baby was fussy, unconsolable, had to be put in the dark. And what I found out from the nurses was that the mother was using, and it was known as the meth city, but more so than the meth, is now thinking back, it was opioid that the baby was withdrawing from. And we were having a hate fest on the mom, and I participated. And I myself, for the longest time, thought, what is wrong with these people? How can they do this to their babies? How can they do it to themselves? So I had a lot of that stigma until in residency, one of my attendings who was doing the medication assisted treatment in our primary care clinic, he sat me down and he's like, no, Sarah, that is not how addiction works. It might start out as something, but it actually changes your body. It becomes a chronic disease. So recognize that. Recognize that the person in front of you is suffering from a chronic disease. And if they're young and they're just starting out and they're doing it, as well as if they have been doing it for decades of their lives, there is something that has pushed them into it. So there's some adverse events. So try to acknowledge that and help them connect with that care. So if they have depression, if they have anxiety, if they have PTSD, help them get that care. And it doesn't make them a less of a human being. They're just people who need help, just like a diabetic, right? You wouldn't turn away insulin from them because they are walking around with a blood sugar of 500 or 600. Sometimes they can do that without going into coma. The body is so impressive. It knows how to reset itself. So that's one. Second is if you're interested in learning more about it, there's a lot of educational opportunities. American Society of Addiction Medicine is a great source. The Osteopathic Addiction Medicine is also another one where you can learn from. The DEA puts out educational activities regularly. Stanford, UCLA, I'm in California, right? They also have a lot of educational CME opportunities for healthcare providers. And I'm sure Florida probably has that too, because Florida has the population of retirees. And I'm sure that opioid dependence without needing to use it recreationally is probably huge. And then chronic pain is another one that we see frequently with this subset of patient population, just because chronic pain can lead to that opioid dependence often. One of the things that I wish my colleagues in medicine would be a little bit more aware of is that just because they're on a medication assisted treatment doesn't mean that their pain is going to be controlled. No. What we do with the medications is we're bringing them from the whole back to the baseline. So now they will still feel pain like the non-opioid user, and they will need that coverage too. So feel free to work with one of the specialists if you need that help to come up with a pain management plan. If you feel comfortable doing it on your own, one of the recommendations is to do controlled smaller amount of pain management if you have to give any prescription. So it's not that they shouldn't get any medicine coverage. Give it. Find if there are other reasons for them to be in pain. I've had a few patients be deferred to our clinic and they have rheumatoid arthritis. Their fingers are just so like deviated. Just looking at it hurts. And I'm like, no, sweetie, you need pain medicine. Yes, you have dependence because you've been taking this medicine for so long. But if you're taking it as prescribed, and you are being judicious with your medicine, following the recommendations of your provider, then you need that. But you also need to treat your rheumatoid arthritis, right? Because opioid is not going to be the magic pill that resolves your disease. So watch out for things like rheumatoid arthritis, ankylosing spondylitis. If there's fibromyalgia, look into that as well. What is causing it? So it's a very big and heavy topic. I think one day the field of medicine is going to go towards where we treat the person individually and customize medicine for their body. But until then, I think that's what I would recommend, and education.
Always education can be the answer for sure. Is there anything else you'd like to share with the listeners today?
Ooh, this is always the fun question.
Yeah.
You know, what I like to tell my patients who are recovering is for them to find the sun in their horizon. These are people who have lost sight of where they want to go. Their goal becomes about how they're going to survive the day and where they're going to get the next hit from, because it's not a moral injury that you find yourself in this disease, right? Your body changes. But if you have a sun in your horizon that you know will always come up after a night, that will always show up after a cloudy, stormy day, you know, it's not like a star where you lose sight of it. You know where it is. Have a big goal and purpose like that. And I think what that does is it propels you forward rather than you having to put in a lot of effort to climb out by yourself. And that sun in the horizon is purpose. So a goal. So I would advise any audience members who are resonating with this, or if you have a loved one who's suffering from this, something like this, having a higher purpose that you connect with can be a huge, important part in recovery, because we're not just a body, we're not just our disease. Our health, our existence is made up, as this is an osteopathic principle, that the body is a unit of mind, body, and spirit. So our health is influenced by all these fields. So take care of yourself in all the dimensions of you.
I was browsing your website and I saw that quote and I really liked it as well.
Yeah, Andrew Taylor, still a visionary, way ahead of his time. I love that the world is now moving towards that holistic approach, because it all impacts our health and how we show up and how we live out our lives.
Yes, I agree, definitely. So where can people find you if they want to work with you?
Yeah, thank you for that question. So, my website has a lot of information. I'm very active on Facebook. The website is bit.ly/transcendent, Transcendant. And it's an intentional misspelling because my goal is to create transcendence who basically have transcended their limits and are living a fulfilling and thrilling life driven by purpose. You can also find me on Facebook under the heading Transcendant You. And remember, there's a misspelling in the transcendent. I'm also on Instagram, but Facebook, I have a lot of content there.
I was wondering about the spelling, so that makes sense.
It's kind of when you go, you're talking about like I'm going to be your confidant. I feel like that makes it a person. So yeah, it was an intentional misspelling. I thought it sounded cool. It sounded like something we can start a tribe of transcendents who go and make amazing changes in the world.
I love it. Thank you so much for joining us on the podcast today. This was a really educational discussion for me, for sure, and I'm sure for all of our listeners as well. So we thank you so much.
It was fun for me as well.
Awesome. We'll put all the information in the show notes. And if anybody is looking for a primary care provider in Clearwater or Tampa Bay, Florida, let me know. Please reach out to us and stay tuned for next week.